Our next speaker is Dr. Bradley Goldberg. He's faculty within the Department of Emergency and Transport Medicine at Children's Hospital in Los Angeles, CHLA, and also serves as the Medical Director of Emergency Management in the Disaster Resource Center at CHLA, and he's going to talk about patient care management. Thank you.
Thank you for that great introduction. I'm going to be speaking to you today about patient care and management, particularly at the hospital or receiving center sites, with emphasis on pediatric considerations. So to begin, just a reminder to everyone that chemical surge, and by surge I mean influx of patients in a short amount of time, can be due to accidental or intentional causes. Here we're just highlighting an incident that tragically took place in the 1980s in India. Union Carbide was a chemical producer and had a massive chemical leak of methyl isocyanate, which caused about 170,000 people in the surrounding community to seek treatment at hospitals. It's estimated about 200,000 children were exposed, and there's a lot of debate about how many people were killed in this event, ranging from a few thousand to tens of thousands. Chemical surge can be intentional. Many people recognize the photos here from the 1995 sarin gas attacks in the Tokyo subway. Sarin gas, an odorless, colorless liquid or vapor, comes into contact with individuals and rapidly causes a organophosphate toxidrome, which can lead to death without treatment. There was about 14 deaths and 50 severely injured in this event, and a few thousand people seeking medical care for temporary vision issues. So shifting into some pediatric considerations, and Dr. Hussain did a great job of covering a lot of these. I will highlight the importance of a few of them again, because we are here today to talk about pediatric considerations, and some of these are really important and I can't stress them enough. So as we know, children are not just tiny adults. There's physical, developmental, psychological, and pharmaceutical considerations that need to be taken into account. One highlight I will point out is the difference in the pediatric upper airway anatomy. Children are at much higher risk for emergent upper airway obstruction, secondary to illness, or in the cases that we're speaking about today, irritant or corrosive agents, just due to their airway anatomy, the narrow diameter. Even a small amount of swelling in a small diameter pediatric airway can lead to life-threatening upper airway obstruction. As Dr. Hussain highlighted, there's higher lung surface to body weight ratios and higher minute volume to weight ratios. So children can have a much more significant pulmonary exposure than an adult counterpart. Toxic gases can be denser than air, and this is a particular vulnerability for children. They are just closer to ground due to height, and also they may have difficulty escaping a rapidly evolving situation, which puts them at higher risk. Some highlights of gases that are toxic gases that are denser than air would be methyl isocyanate, once again, like in the Union Carbide tragedy, chlorine gas, which you can see on the picture on the right, hydrogen sulfide. What you're seeing on the right is from the federal government. This is Project Jackrabbit, where they tested and simulated what a toxic heavier than air plume would look like, and they obviously did this safely out in the desert, as you can see. Some further pediatric considerations, once again, the increased surface to skin surface to weight ratio. We use the rule of nines when it comes to traditional burns in pediatrics when estimating body surface area involvement in a burn injury, and the similar rules and principles apply to chemical burn. So when it comes to decon and what the children might be exposed to when they're being brought to a hospital or emergency department, we have to take into account their perspective. And this is what we see. You know, we're all there with the intention to help and do good by our patients, but in reality, this might be what the patients are seeing. And I want to thank Vicki Olson from Children's Hospital LA Disaster Resource Center for sharing these pictures in this concept today. So children might not realize we're there to help them. And this is a very frightening situation for them. They may or may not be with their parent, depending on the situation. So this should be taken into account. One intervention that we've done during COVID-19 that we find helpful, and we're going to be hopefully implementing into our CBRN policy, our CBRN plans, is use of large picture placards, if available, that we can hang on the outside of our suits. So children could potentially identify that there's a human being inside one of these decontamination suits. So local stakeholders that you should consider working with are child life, social work, and as well as engaging community leaders. Shifting gears to talk a little bit about triage that's going to take place at the hospital setting. So traditional triage, as we know, works pretty well during normal operations, but is definitely inadequate for a mass casualty incident. It's slow, it accounts for medical history, it requires comprehension, and there may be two-way flow. Patients can be triaged and sent back to a waiting room, or they could be brought back to an emergency department. Assuming it takes a triager, one triage person, about 4 minutes to do a traditional triage, it would take about 3 hours and 20 minutes to triage 50 patients in a traditional manner. So MCI triage, the goals are, we want it to be fast, minimal equipment needed, one-way patient flow, and with the goal of preserving limited resources for the patients that need it most. So there's lots of different MCI triage systems out there. I am not here today to tell you which triage system is best. This is continuously examined in disaster academia and in publications. At LA and in LA County, we use START and Jumpstart triage tools. I don't want to speak for every children's hospital out there, but there does seem to be growing consensus at children's hospitals that this is the popular tool of use. I hope in the future we can come to some kind of universal agreement in the US about tools to use. But there's many others out there. SALT is very popular as well. So when looking at the Jumpstart and START triage tools, they take into account the differences in child physiology and developmental status that we've already spoken about. Easy way to remember it is a child is much more likely to have a primary respiratory problem that's reversible compared to an adult. So in children, you have the opportunity to jumpstart their respiratory effort with rescue breaths, whereas that intervention does not exist for adults under START. So as we already discussed, children may not be able to follow commands, they may not be able to walk, and measuring their perfusion, especially in a cool or cold environment, may be difficult. What age cutoff should be used for these tools? You may have very mature looking teens or young adults that are well developed, and you could have adult age people that look very young. So the key really is just to use your best judgment. They appear to be a child, use Jumpstart. They appear to you to be an adult, use START. And this is kind of in line with the American College of Surgeons in terms of trauma definitions, using birth to age 14 as pediatric definition, and adults 15 to 64 years of age. And the elderly are another group that requires special considerations of being 65 years and up, but that does not factor into the START or Jumpstart tool. So we're not here today to learn this tool in depth, but this is what it looks like. This is the Jumpstart, the pediatric version of the algorithm. We will do one sample case in just a moment, but there's lots of different vendors, companies, and agencies that have versions of this that are publicly available. So just a comparison of normal versus chemical hospital operations, particularly with our interface with EMS in the emergency department. So under normal operations, EMS runs and self-arrivals come to the hospital. And what you need to take into account when thinking about your plans for a chemical surge of patients is there's likely going to be different areas of entrance depending on how the patient is arriving. So there's often an ambulance entrance and a self-arrival entrance. These patients all get funneled through a triage process, which can vary institution to institution on exactly how that's accomplished. and then the patients are brought to the main ED or the treatment area. During chemical operations, during a patient surge, or even just a few patients, we need to take into account decon and a few other things we're going to touch on here. So once again, you may have people coming by EMS, but you may also have patients that were scooped by Good Samaritans or passerbys and brought to the emergency department. And this has been demonstrated time and time again in disasters in the United States, where lots of patients will self-arrive in private vehicles. So once again, coming to two different entrances. The difference here is while we are going to perform triage, when dealing with a chemical exposure and a potential reversible toxidrome to a chemical, there are immediate interventions and antidotes which should be offered immediately prior to fully decontaminating and bringing the patient into the emergency room. So the next step would be decon, and then bringing the patients to the main ED treatment areas. So often the hospital is not the site of where the chemical incident occurred. Often that is distant, and as Dr. Hussein discussed, EMS will be usually handling that and arranging for the patients to go to area hospitals. From our perspective at the hospital, we don't know necessarily if the patients have been properly decontaminated. We have self-arrivals. So we establish a warm zone, or what we call a contamination reduction zone, for patients arriving from this incident to our emergency department. The goal is to get these patients decontaminated through this zone to the cold zone, which is the treatment area in the ED. So the hot zone doesn't necessarily apply to your hospital if the incident is taking place at a distant site. So talking about those immediate interventions and antidotes, which you should build into your plans of how you will administer these in a quick manner to patients. So first is you're going to want to open and maintain an airway for a patient with an airway issue, offer spinal motion restriction for trauma of the neck if needed, needle decompression of tension pneumothorax, control of massive external hemorrhage and applying tourniquets, and administration, ideally intramuscular injection of nerve agent antidotes via auto injectors. And on the bottom there, you can see some of the Mark I auto injectors. You may not have these available to you at your hospital. So when discussing with your team what your plan would be, you should definitely incorporate pharmacists and pharmacy into your plans, because if you do not have these auto injector pens, you're going to need a plan for how to quickly draw up these medications in a quick manner. Even if you do have federal chem packs on site in your hospital, it is going to take a while to mobilize these and get all the authorization to start using them. They're often not located in the emergency department. I believe they weigh somewhere between 500 and 700 pounds. So there's a lot goes into getting one of those mobilized. So because I'm in Los Angeles, I put in some Hollywood references. Hollywood often gets it wrong when it comes to medicine. You're seeing two scenes from The Rock on the left and Pulp Fiction on the right of antidotes being administered. These auto injector pens are just like EpiPens. We put them right into the thigh of the patient. We do not use large needles like this. You are not stabbing the patient in the heart with a 6-inch needle. So this is fiction. This is reality. So we're going to bring it all together with a rapid scenario. Your hospital's emergency department was notified by EMS of an evolving MCI incident. As we had discussed earlier, there was a train derailment. There was children nearby. Details are sparse, but there's reports of multiple people collapsing, sweating, vomiting, seizures being reported, and it's relayed to the hospital that there's suspicion for chemical exposure. So this is very generalized, but the first 15 minutes, what you should be thinking about at your institution and what you should be developing into your plans at your hospital should be focused on how to really maximize the first 15 minutes from notification to prepare yourselves for what might come. So we'll talk a little bit very briefly about 15 till 50. That's the idea of receiving 50 patients within 15 minutes notification of an incident. So you're going to want your staff to huddle, assign tasks, activate your MCI plans, request help early, involve your pharmacists and anyone that might be needed to mobilize chem packs if needed, consider rapidly decompressing your ED, calling trauma alerts if needed, getting facilities involvement to open up your decon showers or rooms if you have them at your facility, and start identifying supplies. So this is just a very generic list of things to think about I put together that you should be thinking about in your plans, and particularly in your first 15 minutes. So your first patient arrived by ambulance. They appear school age, maybe they're 7 to 9 years old. EMS said there's lots of secretions and wheezing and route, and then they started seizing when they pulled up to your emergency department. So this patient is going to be evaluated in a triage area, and you're going to have to think about at your institution where it makes sense to do this. So we're here. The goal is to get them through decon and into the ER. So we're in the contamination reduction zone. We're trying to get to the cold zone. So at triage, this patient looks 7 to 9. They were actively seizing, but we did give them intramuscular antidotes. Now they're somnolent. Their respiratory rate is 12, and you're not sure if you can feel a pulse. So looking quickly at this jumpstart algorithm, this patient is obviously not walking. They are breathing. And if you move your way down the left-hand side of that algorithm, their respiratory rate is 12. They are breathing too slow. So they are an immediate triage category. So after this patient has received immediate interventions and antidotes, we were told that they're not sure if they were decontaminated. So we are going to bring them through decon. I just wanted to share a few videos of decontamination that we did in an LA County drill at Kaiser Permanente last year. You can see the use of a laundry basket for infants. They're slippery. You do not want to drop them. And on the right there, you can see a laundry basket being used as well. But take note, one of the feedback we gave for this drill is those were very coarse brushes. And Dr. Hussein mentioned that this could be very abrasive for particularly small kids and their skin. So we recommended a softer tool or brushes in future drills and in patient care. Very, very important. You must keep children warm after they've been decontaminated. They can get cold very quickly, particularly babies, and this can add insult to injury and contribute to rapid circulatory collapse. So congratulations, you've made it to the treatment zone. Just very broad strokes, things you want to think about at your facility is how would you utilize space most efficiently and divide your ER or your facility into different treatment zones. Identify stakeholders that you need to use these untraditional spaces. And I think we all saw how complicated and complex that was using unlicensed space during COVID-19. And who would staff these areas? PEDS equipment considerations. What would you do if you had to intubate 10 children in the next 30 minutes at your facility? Do you have the staff to do so? Do you have that equipment? And where is it stored? How far away is it? How do you get more? So these are all things that should be thought about when developing your protocols at your centers. And also, what just-in-time resources do you have available if you primarily take care of adult patients? A quick plug for the 15 till 50 program, which I mentioned. I actually saw Chris Riccardi in the audience, who is one of the champions behind this program. If you are feeling overwhelmed when you're hearing this, or you're just looking to evaluate your current protocols and plans, this is a great place to start. And this is publicly available at CDPH, the California Department of Health, Public Health's website. Another plug for the disaster triage game. If you want to learn more about Jumpstart and START triage algorithms, this is open to the public, and you just need to register. It's free, and you can practice online. Another resource that I personally found really helpful was taking an AHLS, Advanced Hazmat Life Support course. I found it to be a great resource, particularly if you're on the clinical side and want to learn more about different toxidromes, the chemical pharmacokinetics, and the antidotes. It also covers decon and a lot of other useful things. So that's me, and please reach out if you have any questions or want to collaborate with us in the future. Just some fun photos on the left there. That was a drill I participated in Israel and Jerusalem. This was a chemical attack simulation. The Israelis have a lot of experience in preparing for these events. The middle photo is from Kaiser Permanente's drill in LA County last year. And on the right is just a picture from our special pathogens training. Thank you very much, everyone.
Dr. Goldberg, thank you so very much for your informative presentation. It was packed full of great information. We appreciate it so much. I'm going to ask the same question David asked earlier. What are the top 3 takeaways you'd like the audience to receive?
So I think my top 3 takeaways are, 1, to have a plan and practice a plan and continually reevaluating and updating your plan. It's a constant. It's never fixed. So I know at CHLA we're constantly updating our plans and to drill them. Number 2 would be, it's very important to drill these plans. Having everything on paper is one thing, but acting it out and getting people up and out of their chairs and pulling supplies, requesting help, using your mass communication tools, it becomes very complex very quickly. And I think the last thing is just around triage. It's really important to have a triage tool that your team is in agreement to use and has training with. Once again, it's not as important which tool you're using, but to have one picked out and be really good and efficient using it.